So good night, everyone. I would like to welcome all of you to the second Adult Strabismus webinar. This webinar is organized by the Adult Strabismus Committee of AAPOS, and most presenters are members of this committee. We have an amazing group here tonight and hope that you will enjoy the presentations. Before we begin, I will go briefly over the format. We have 6 panelists. Each of them will present a case, but will stop before giving us a surgical plan. At this point, a second panelist who does not know what the presenter did will give us surgical options and will tell us what they would do. After this, we go back to the initial panels and the presenter will show the surgical treatment and the patient outcome. So again, the discussant is not aware of the treatment that was given to the patient. During the session, you can ask questions using the Q&A section. Do not use the chat for this. The panelists will try to answer the questions as we go, and we will try to address some of them at the end of the session if we have time. So let's get started with our first panelist. This is Dr. Melanie Kaslas. She's an assistant professor of ophthalmology at the Harvard Medical School and at the Boston Children's Hospital. Her discussant will be Dr. Edward Kubera. You're on, Melanie.
Thank you, Dr. Capot, for having me present a case at this wonderful seminar. So I'll be presenting a case, the surgical treatment of a mechanical strabismus. I have no financial disclosures. My patient came to see me for further management of her double vision due to difficulty with persistent vertical binocular diplopia. But she was quite concerned that she wasn't driving safely. She's a 53-year-old woman with gradual onset of double vision, binocular and vertical, about 8 months prior to presentation. And she's residing in Arizona for most of the year and was treated locally with prism and steroid injections, but with no improvement. She actually came to presentation to her primary care doctor because of the double vision, who sent her to a local comprehensive ophthalmologist who diagnosed, vertical binocular diplopia and obtained an MRI. And this was 6 months prior to presenting to me. And there was left inferior rectus muscle was dramatically enlarged, noted on the report 6 times normal size, and the right inferior rectus muscle was 2 times normal size with minimal enlargement of the medial rectus muscles. Then her comprehensive ophthalmologist sent her directly to the local eye plastic surgeon in Arizona, and he felt there was no indication for orbital decompression, and he suspected thyroid-associated orbitopathy as the cause of her double vision, and recommended Q-weekly Kenalog injections, which she had for 4 weeks. But she still did not have improvement. So she came to Boston. She resides in the summer in Massachusetts and came to see us at Boston Children's Hospital. She notes that after this workup for her double vision, she did see her primary care provider again and an endocrinologist who diagnosed clinical hypothyroidism. Her TSH was quite high, and she continues on Synthroid. There were no autoantibody levels drawn, but presumably she could have had perhaps Hashimoto's thyroiditis, which has been described with thyroid-associated orbitopathy. Other pertinent past medical history includes being a breast cancer survivor, status post a left mastectomy. She's a wedding planner and is quite active. She was a smoker, 15-pack years, and she quit 1 year prior to presentation, and she has no allergies. So on exam, when she presented to me, she was wearing a hyperopic prescription in the form of a progressive addition lens with an add of +2. She had ground in 3 prism diopters of base out prism and a 15 prism diopter base up Fresnel to the left lens. She had excellent visual acuity. As you'll see from her photos in a minute, she has a marked retraction of her left upper lid on external exam, but no gross proptosis. Her pupils were equally round and reactive with no relative afferent pupillary defect, and her visual fields were full to confrontation, and her anterior segment was quiet except for just trace nuclear sclerosis of her lenses. She had normal intraocular pressure and a healthy appearing fundus. So When she came to see me, these are her motility pictures as well as her measurements. And you can see here in primary gaze, she's fixing with the right eye. It has a significant left hypotropia with marked eyelid retraction, with fairly preserved horizontal motility and marked restriction to up gaze, as you can see here, of the left eye. So she did have some stereopsis with an extreme chin-up position, but had this really huge left hypotropia. So our discussant, Dr. Carrera, will actually give us input and advice as to what I should do after my first surgery. So you will see what I did now to treat this very large angle mechanical strabismus in the setting of thyroid disease. And then I will ask his help and stop the slides after I share with you what happens after the first surgery. So at the first surgery, under general anesthesia, I performed 4 reductions and again confirmed marked restriction to superduction of the left eye. And it was mildly tied into infraduction on the right eye. And so I performed an intraoperative relaxed muscle technique described by Trabulsi as well as others with a right superior rectus muscle recession of 4 millimeters and a left inferior rectus muscle recession of 9 millimeters. In the recovery room where I do an examination to see whether we need to do any adjustment, at least as a first pass, I felt she was in an acceptable alignment in the distance. She did have a left hypotropia of 6 prism diopters, and she was able to fuse with a 6 base up. And at near, she was orthotropic in primary near gaze as well as reading, all by alternate prism cover testing. So I did not perform any suture adjustment at that time and left her at these numbers. So she went home and she was doing quite well, but she communicated with me from Arizona that she was developing double vision, but in the reverse fashion. So here, she finally came to see me, and this is her pre-op surgery number 2 motility and measurements. She has now a reversal of her left hypotropia. She has a marked left hypertropia with corresponding significant restriction to superduction of the right eye. And she has no stereo in any gaze and has a very large angle, now left hypertropia. So, and double Maddox rod shows maybe slight X cyclotorsion. So I'll stop here and ask Dr. Carrera to just share with us what his thoughts are, what I did wrong, or if this is related to the disease process, and what he would do next for this patient.
Thank you, Dr. Kozlovs. First, I do not think that there was anything wrong with what you did, and I think the outcome from the initial procedure, where there was a residual of about 6 prism diopters hypotropia, is an exceptional result. That's exactly what I would target, somewhere between probably 5 to 10 prism diopters of undercorrection. This is a very unexpected result, especially because the superior rectus muscle is not usually anticipated to behave as unpredictably as an inferior rectus. We know that strabismus surgery in thyroid eye disease is notoriously difficult to predict. Groups from, say, Stanford, Dr. Scott Lambert, for example, reports about a 24% re-op rate. Joanne Hancock's from Moorfields reports about a 19% reoperation rate. This is for general strabismus thyroid eye disease, but for vertical strabismus, it's even more unpredictable. And Dr. Natalie Kerr has an amazing paper out reporting anywhere from 40 to 50% risk of overcorrection with a unilateral inferior rectus recession. And so superior rectus, again, there was a group in China that recently published a paper showing a 76% success rate with just a unilateral superior rectus recession. And most groups agree that the superior rectus does not tend to behave so unpredictably. So what could have caused this? It could be a slipped muscle, it could be a stretched scar. There could certainly be some of the other reasons for overcorrection, like absorbable sutures rather than non-absorbable sutures for the inferior rectus. And so in terms of what to do when you see something like this, we generally want to undercorrect reports anywhere from 2 prism diopters to up to 9 prism diopters of undercorrection, depending on the group. Dean Sestari, for example, recommends 1 to 2 for just strictly vertical strabismus. Whereas if there's vertical and horizontal, you aim to undercorrect 7 to 9 prism diopters as an example. I generally undercorrect by about 5 to 10, depending on how tight the muscle is. And so In a case like this, I would want to do more subductions and find out, is the right inferior rectus tight? If not, is the right superior rectus very lax in the sense that it looks like there is a slipped muscle? The left eye, in terms of motility, looks incredible after the 10-month post-op. And so I would try my best not to touch the left eye here, although I would still want to explore it and see if there was anything unusual about tightness of any of the vertical muscles here. If the right inferior rectus muscle is tight, then I would recess the right inferior rectus muscle with a non-absorbable suture, something like Surgidac. I would target somewhere between 20 to 25 prism diopters here in anticipation of a very large overcorrection. If the inferior rectus is not tight, then I would probably advance the superior rectus muscle back to its insertion, maybe even consider a little bit of a resection so that you can advance it further, and possibly include the right inferior rectus as well with a very small recession. I would want to avoid the inferior rectus if I could, because again, we know how unpredictable it is. But given this kind of history, I don't know if you used absorbable or non-absorbable sutures. If you used
Yes, I use absorbable. I tend to try to avoid Merceline. I've gotten suture granulomas, which are very troublesome. So yes, I just will stay with Bilateral.
Thank you. I've seen the same, and for us with Surgidac, we tend to start 5 millimeters back from the insertion and then hang back from there, resecting if we need to in order to get some further hang back as necessary. So yes, I would use absorbable. Non-absorbable rather, but if I were to use absorbable, I would definitely plan for a large overcorrection, like 20 prism diopters overcorrection, given this kind of history. Very difficult case.
And so from what I'm hearing, then you would prefer to restrict the surgery to the right eye, and unless if really the forceductions were suggestive that I should do the left eye as well.
That is correct, just because of how great the motility of the left eye looks in this second picture.
Not to compromise it. Yes. Yeah. Thank you so much. Certainly the nomograms really, when you have a fibrotic muscle in this case, really do go out the window, so to speak. And I have been impressed by the literature by Dr. Trabulsi and others, highlighting the relaxed muscle technique. And I was hoping that, that it would be more predictable, but she was not. And this is why we're bringing this case to our wonderful panel and to Dr. Kura's very excellent comments. So may I go to show you what I did and how she did? Or are there any other comments, Dr. Kura, that you'd like to make?
No, please.
Thank you. So very, very much so, wonderful input from Dr. Carrera. And what I found is, and definitely at the time of surgery with my thyroid patients, of course, for all of us, forceductions really do inform a lot of what we do. And I did find marked restriction to supraduction, so consistent with a tight inferior rectus on the right, and mild tightness actually to infraduction, moderate restriction, to infraduction of the left eye, suggesting that the superior rectus is now tight. So I basically did the corresponding complementary procedure of what I did initially, but now with a right inferior rectus muscle recession and a left superior rectus muscle recession. And she did not have as good an outcome initially in the recovery room. So I did ultimately iteratively adjusted her in the PACU to ortho in the distance and an exotropy of 6 at near. So I did not follow the first dictum of undercorrecting, and I was just happy that she was able to move better after I did these sequential adjustments and that she was seeing singly. So, here, just to show you what she looks like 7 weeks after this second surgery. I think I got lucky with this because, it's been described to have, over, you can have with those large inferior rectus recessions, certainly in non-thyroid patients, described by, Irene Ludwig, progressive, like a pseudo tendon, progressively reducing the inferior rectus function. is certainly something that can happen, but happily, with thyroid eye disease, these muscles do not behave like other, muscles are not affected by this terrible disease. And happily, she had a very good outcome. And she's back in Arizona, and no news is good news. So I think she's still doing quite well. Thank you.
Thank you, Dr. Casas, for sharing that great case. As we can see, there are different options, and we may all approach the patient differently, but hopefully we'll all get a good outcome as you did. So we're going to move on to the second speaker. That is Dr. Mustafa Abdelhafez. He's the Chief of Pediatric Ophthalmology and Adult Strabismus Unit at the Maghrabi Eye Hospital in Jeddah, Saudi Arabia. Special thanks to him because it's 3 a.m. in the morning for him. So we appreciate you being up at this time. His discussant is going to be Natalie Kerr.
Good evening, or I can say good morning in the Middle East. And thank you, Dr. Hilda. I want to present a case. It's not so similar like the one with Dr. Melanie. It's a thyroid patient, above 40 years old, man, known to be has thyroid dysfunction. He had left eye limited elevation, which was more on epiduction. He did the surgery. This is the mortality before the first surgery. He had left hypotropia, which was more on the left gaze and up gaze. Severe limited elevation on epiduction for the left eye. It seems that he had very tight involved inferior rectus muscle with thyroid ophthalmopathy. The first surgery was the recession, maximum recession for the left inferior rectus. After surgery, he was nearly orthophoric in primary position, very mild hypotropia in primary position, but still seeing double in primary position, which disappeared by a little bit up shift by the chin up, sorry. He still had limited elevation on up gaze, which was equal on epiduction and adduction. 6 months after that, the patient presented to us in the clinic. He had recurrent hypotropia on the left eye, but it was more on the right gaze and more on up gaze. In addition to that, he had exotropia. It appears that it's a pattern exotropia, which was 25 prism diopter on up gaze and 40 on down gaze. As you see, this is the patient in primary position, and when he fixed by the left eye, the right eye goes up and out, and this is the right and left gaze. Again, this is his orthoptic, and this is the deviation, the vertical and horizontal deviation, which appear to us. If you allow me, Dr. Natalie, to ask you, what's your opinion and what's your suggestion and advice to us to do in such case?
Thank you, Dr. Mustafa. I certainly commend you on finding a difficult case for me to discuss and an unusual one, but clearly there's a theme that the second surgeries happen in thyroid eye disease, and first surgeries sometimes have unpredictable results. When I think of an A pattern exotropia in thyroid eye disease, particularly post-op, you think of the A pattern exotropias that you see following large bimedial rectus recessions and large bilateral inferior rectus recessions, something that folks had started doing nasal transpositions for inferior recti at one point, but I think have stopped because of torsional issues. But you didn't do any of that kind of surgery. You did a very reasonable single muscle surgery that looked like you had a good result. So I don't think that's what we're dealing with. The other setting I've seen exotropia in thyroid eye disease is when there was an exotropia prior to the development of the thyroid eye disease. So unless something's happened in the last 6 months, where maybe you could come up with some wild story that the patient used to be XT and then had medial rectus tightness and then had some relief of that and they went XT again, I don't think that's what you're dealing with here. And also then it looks like there's a recurrence of the inferior rectus restriction after a very reasonable large inferior rectus recession on that side. So a couple of things come to mind. And the first is looking at the limited, if you want to go back maybe to the motility photos, looking at the limited deduction that we're seeing. And it makes me wonder if we've converted from a restrictive strabismus to a paretic strabismus, because we all know that myasthenia can occur in the setting of thyroid eye disease, and that might create the picture that we're seeing. So instead of a recurrent left hypotropia, maybe we've also got a paretic superior rectus that's inducing this instead of a tight inferior rectus. And same thing with our adductors, our medial recti. So that's one thing I would want to know and explore further, maybe with testing, with forced ductions, or looking at the differential of IOP from right and left and up and down gaze to confirm whether we're dealing now with a paretic versus a recurrent restrictive syndrome. The other thing that I think of when I look at this with the left hypo that is now worse in elevation and adduction of that left eye is, do we have a superior oblique that's restricted? So I'd want to know, is there any cyclotorsion that can be measured for this patient? So those are the kinds of things that come to mind. Like I said, I have a lot of questions about what's happened in the last 6 months. Depending on what the answers are to these questions, and after we explore them, either in clinical testing, in the clinic, or at the time of further surgery with forced duction testing, would then inform what I would do with this. If I didn't find myasthenia, if I had 6 months of stable measurements, if I found that the lateral recti were tight, which is extremely, extremely rare, the procedure of choice I would consider would be bilateral lateral rectus recessions with a transposition for the pattern, so downward, and then also consider a right superior rectus recession. But again, at the time of surgery, I would make sure that I don't have any superior oblique involvement that could be producing this picture as well. So that's what comes to mind, but it's a very unusual case. So I'll be fascinated to hear what you figured out and what you decided to do.
As we know, the patient has or had A-pattern exotropia. The hypotropia was more on ipsilateral gaze and up gaze, as you see here. We have to put in our consideration that he did previous inferior rectus maximum recession for the left eye. And this large angle left hypotropia increased on the right gaze, exotropia, A-pattern, and minimal excyclotorsion for the left eye. As you said, Dr. Natalie, you have to put in our consideration the superior oblique involvement. We all know in cases of thyroid ophthalmopathy, the involvement comes more to the muscles more than the tendon. And very few cases, superior oblique may be involved, especially in acute and active stage. So if we have to put in our consideration, if you do a surgery for the superior oblique, we have to test for the activity of the thyroid first prior to the surgery. In some cases, the superior oblique involvement masked by the coexistent inferior rectus involvement, the huge or large coexistent. So the CT and the imaging of the orbit is very important in such case. Actually, I'm trying to open my video, but there's something here. In this case, we did a superior oblique. Actually, I did the forced duction test. It's limited in many, for the left eye, it's limited in many directions, but it's more in up and in gaze. So we decided to do the superior rectus lengthening procedure. We did superior rectus expander around 12 millimeter for the patient. And this is the picture of the patient. The patient had very minimal hypotropia of the left eye, after the surgery, exotropia becomes less. Actually, I added a lateral rectus of the left eye, lateral rectus recession, the maximum. It helps in the correction of the exotropia plus the superior expander of the left eye. Patient had minimal vertical deviation, minimal diplopia, so we put him on prism glasses after that. Thank you all, and thank you, Dr. Natalie, for your advice and your suggestion.
Thank you for sharing this case with us. And again, superior obliques are not frequently involved, so we'll get probably some feedback from the panelists at the end, whether imaging would have been useful in a case like this. But for the sake of time, we're going to move on to the next presenter, Dr. Edward Brewer. He's an assistant professor of ophthalmology at the Wilmer Eye Institute, and the discussant will be Dr. Melanie Kaslos.
Hi, everyone. Thanks again for your attention. Thank you, Dr. Capo, for organizing this, and thank you, AAPOS. I have no financial disclosures. My case involves a 39-year-old male who came to us with a chief complaint of horizontal diplopia for a year, a significant past medical history of neurocystic sarcosis with resection of lesions in 2021. He does not have any significant ocular history. Family history is not contributory, and the social history is contributory in the sense that he was an exotic meat taster from South America, and that's probably what led to the neurocystic sarcosis. So we see on imaging that the MRI shows that there's an enhancing systemic focus along the fourth ventricle, outflow tract with surrounding edema involving the dorsal pons and the periventricular cerebellar hemispheres with obstructive hydrocephalus. The calcified granulomas were consistent with neurocystic sarcosis. His base exam visual acuity is about 20/40 in both eyes. At best, it fluctuates. It had fluctuated throughout his treatments. He does have a prescription for glasses, but the glasses do not improve his vision any better than 20/40. He otherwise has mild lagophthalmos of the left eye with involvement of the seventh cranial nerve from the lesions. Otherwise, no other significant findings on exam. Sensory motor exam is significant for a large angle esotropia, worse on the right eye than the left eye, and a concomitant complete horizontal gaze palsy bilateral. So he was not able to abduct the eye at all, not even a flick of movement. Dahl's head and vestibular ocular reflex were negative. He could not abduct the eye at all. Optokinetic drum was non-informative. We did not see any movements with the optokinetic drum. So the differential for this case is bilateral horizontal gaze palsy. Most likely this was nuclear, as there was no Dahl's head response, and possibly bilateral abducens nerve palsy as well. We did look at the MRI to see if we could identify anything that would help us with the lateral rectus muscles here. The lateral rectus muscles are on the MRI were not specifically commented on by the radiologist, and there was no, this is the best cuts that I could find, and it was also not too contributory for my plan. And so Dr. Kaslos is going to help us and see how would we approach a case like this when there's a complete bilateral horizontal palsy and you're not sure if there's any abducting ability of the lateral rectus muscles.
This is
I'll go back to alignment.
Yeah, thank you, Dr. Coyer. This is a fascinating case, both diagnostically and from a treatment standpoint. Thank you for bringing that slide back up. Did you do forced duction testing? And
forced ductions intraoperatively showed 3+ tightness of the right eye and 2+ of the left eye, medial rectus only.
Thank you. Yes, and in terms of just the fact that this is not supranuclear, that localizing the lesion to the dorsal pons where there was such edema and the cysts that were involved, you presented the MRI findings, but this was prior to his neurosurgical resection. Do you have any follow-up MRI findings that were different, or was that done after?
There was
damage, additional damage to that area.
The MRIs that were for follow-up, I do not have pictures of them, but the reports showed that they were stable sort of findings status post resection. They did not comment much on further damage to that surrounding area.
There was a case report in the Japanese literature about certainly a much milder, duction deficits, from neurocysticercosis, but with some response to antihelminthic treatment, albendazole and steroids. And was there any, modulation of this, picture with such treatment, and what type of treatment did he receive?
To my knowledge, there was no treatment that I could see specifically.
Except for the surgery? Yeah.
Except for the surgery.
Uh-huh. Okay, thank you. So with regard to the approach, with this type of complex strabismus, just general, sort of guidelines that I always, speak with my patients in such a situation is to really set expectations. And certainly I'm sure that he wants to be able to have single vision in some field of gaze, because right now he does not. And to not have to adopt such an extreme head posture, also for comfort reasons. So those are the two reasonable goals that we can look at, and certainly to prepare the patient for multiple surgeries, perhaps even stage surgeries. In my review of the literature, I found a small case series from Dr. Evelyn Pace and Dr. David Coates and Cindy Avila back in the late 1990s, but it was a bilateral horizontal gaze palsy, patients with bilateral horizontal gaze palsies, but unilateral esotropia. So this, I think, is going to be a wonderful publication at some point, because this is not only just, it's a sort of bilateral esotropia, bilateral, nuclear 6+ involvement probably of the PPRF with the horizontal gaze palsies. So extremely, difficult to treat. I don't think we have too much guidance except for sort of the basics, again, going to forced ductions, which you described, having the tight medial rectus muscles, and then seeing what the patient wants to do. In terms of our treatment toolbox, Botox could be, if he was, reluctant to have incisional surgery, that could be helpful, perhaps even diagnostically as well as therapeutically, if albeit temporarily. And so that's one consideration. But I think I would definitely prepare him for incisional surgery, and I would consider, definitely wanting to release the tightness of those medial rectus muscles. So I would do a bimedial rectus muscle recession. But in addition, we have to think about, how to not just perhaps restore a little bit of, motility. With a gaze palsy, that is hard to predict, but we have to start thinking about a transposition procedure. And there's a variety, of course, whether it's a partial tendon transposition of the vertical rectus muscles to the lateral rectus muscles. And this was done in the case series with that Dr. Coates and Dr. Pace presented in their patients. And that could be helpful. There's the full tendon transpositions with or without augmentation sutures, Foster modifications, which can be quite powerful. And also, you can do in our group at Children's, we've published and looked at superior rectus transposition procedures with loop myopexy, at least in cohorts of patients with 6 nerve palsy and esotropic Duane syndrome with good success. So my choice would be to do a bimedial rectus muscle recession on adjustable suture with bilateral superior rectus muscle transpositions with a loop myopexy. So yes, I look forward to hearing what you did and how he did.
Thank you, Dr. Kozlas. And just like you had mentioned, there's not much in literature for this. There was a case series of 5 patients done in Turkey that looked at unilateral horizontal gaze palsy, and they found that with vertical muscle transposition, it tended to result in some undesired vertical diplopia, whereas recess-resect standard horizontal procedures tended to improve gaze, and improve alignment, and improve move motility in the direction of the horizontal gaze palsy. But there's nothing for bilateral. I ended up talking to him about staging the procedure, starting first with a recess-resect of the right eye and recession of the left medial rectus on adjustable sutures. He was all on board with the transposition if we needed to do further surgery. And so 1 month post-op, we found that he was actually ortho by Krimsky. And however, being ortho, he still had diplopia, needed 20 prism diopters of prism to fuse. And so we placed a Fresnel onto his fashion glasses and saw in post-op month 2. He remained ortho on Krimsky, no improvement in motility at all, but he was able to reduce the Fresnel to 10 prism diopters with intermittent use, no diplopia at near, only for distance. Post-op month 3, he's now at 5 prism diopters of intermittent use of a Fresnel. Again, no diplopia at near. So thankfully, we have not needed to consider the transposition yet, but we don't know long-term what will happen here.
That's a wonderful result. And you had progressive improvement over time, which is quite interesting.
Very surprising.
Yes.
Thank you.
Thank you.
Thank you for another fascinating case. I think for the sake of time, we're going to move on. Next presenter is also Steve Archer. He's the Ida Lucy Jacobuzzi Professor at the University of Michigan Kellogg Eye Center. And that discussant will be Dr. Linda Daggy.
Okay, well, I'm going to talk about something that is a little more straightforward. It's not a thyroid case, and it's not a diagnostic question. I don't have any financial disclosures. This is a 44-year-old man. He's had a right face turn since childhood, hasn't had any previous treatment, 20/30 in the right eye, 20/20 in the left eye with a myopic correction. A little bit of stereo, I'm not sure how much I believe that, but has a 30-degree right head turn, and 30 base out on the left eye is of no help. That may be useful later, we'll find out. So here he is. He has a large esotropia, and it measures 40 prism diopters at distance and near. And when I saw him, I looked at him, I said, there's no way that's 40. But those were the numbers my orthoptist gave me. I said, they must be measuring a secondary deviation or something. But in fact, he really is 40 with simultaneous prism cover in primary position. He can't abduct even to within waving distance of the midline on his right eye. And he has obvious retraction on adduction. So pretty straightforward Duane's, except for the size of the deviation. So here are his numbers. He's 40 with a little hypo in primary position. It's too big to measure in right gaze, and he's got 20 ET in left gaze. So I'll let Linda say what she would do with this.
Okay, so this is a very interesting case, and as you note yourself, it's a little bit more extreme than some of the Duane's ET we see. I'd love you, Steve, could you go back to the photos for just a moment? So a couple of things you mentioned are notable and are interesting in the photos. The first, you mentioned that even with the 40 base out, he was having a hard time fusing. And I noticed that both in the numbers and in the images yourself, he has a little bit of a hypotropia. It's not sort of a pure ET in what we can choose to call primary position. A couple of other aspects of his case that are interesting, just looking at the imaging, is that he has definitely better abduction in up gaze of the right eye than in down gaze. You know, he has a really pretty profound ET in the down gaze to the right, quite cross-eyed, whereas up gaze to the right, there is definitely better movement of that eye. And all of that feeds into some thoughts I'm having about perhaps the best way to manage him. I suspect you'll when you take him to the OR, as I'm sure you did, he probably has quite a tight medial rectus. He has, you know, definite co-contraction. He's got retropulsion of that eye, not only in adduction, but it almost looks like even a little bit of adduction and up gaze, that eye is retropulsed. So that medial is going to be quite tight. So just relaxing that, you're going to get some bang for your buck. You know, the usual thing we do in Boston in terms of improving abduction in these folks would be to do a superior rectus transposition and augment it. But I'm almost wondering whether you might want to consider an inferior rectus transposition in this case for two reasons. The first is it might possibly reduce some of the hypotropia. The second is you may possibly be able to improve some of the abduction in that down gaze direction. I'm not sure that if you did a superior rectus transposition, you'd help him much in down gaze, and it'll still leave him with a very big head turn, I think, sort of in down gaze, for example, for reading. An alternative would be a sort of a more balanced transposition, like a Nishida type of transposition along with the medial rectus. And another thing you could do to augment the reduction in esotropia is to put the left medial on an adjustable and relax that a little bit too, but I'm not sure how much benefit that will be here. So I think the key aspects of this case that make it interesting are the degree of co-contraction, the fact that the restriction of abduction is notably greater in down gaze. And that is a much more important gaze than up gaze, because that's reading a book, running down a flight of stairs. And you might therefore want to consider a different kind of transposition procedure. Because of his severe co-contraction, I know that some have tried recess-resect procedures on some mild Duanes without co-contraction. I would not try that here. So I guess those are the key features: the small hypotropia, the greater limitation of abduction and down gaze, which would change a sort of more direct approach.
Okay. Yeah, interestingly, at least in primary, he doesn't measure much of a V pattern. So here's what I did. I did a right medial rectus resection, 5 millimeters, and a right lateral rectus resection, 3 millimeters. And post-operatively, his stereo has improved a little bit. His abnormal head position is gone. He has no diplopia in left gaze, although he feels his right eye may not track quite as fast to the left. And he's okay if he looks slowly to the left. And here he is. So he is very straight in primary. Measures ortho. Has a little abduction past the midline. As you say, it's a little better in up gaze. He looks pretty good in down gaze. Those are his measurements.
Well, that's really nice. So can you tell us a little bit more about how many patients you've chosen? And since you've chosen in a case like this, which I would have sort of hesitated to do a recess resect, how many of these have you done on Duane's patients?
Oh, probably half a dozen. So at any rate, just a couple of other things I want to point out. So one of the concerns about resecting laterals is making the retraction worse. In primary position, if you look at his pre and post-op, looks like he's maybe a little better post-op. Left gaze, admittedly, maybe he's not trying to look as hard to the left in the post-op photo, but certainly haven't made the retraction any worse and probably made it a little better. So just comparing it to SRT, just some other things that I would compare. So one of the reasons for the transpositions is to improve abduction in the affected eye, but patients with Duane's don't complain of diplopia there. So that kind of scratches a place that doesn't itch. And he never complained of diplopia in right gaze, and he still doesn't. I didn't create any diplopia in left gaze. I just operated on a victim of SRT who had a big restriction in contralateral gaze. I'm sure not all surgeons are as skilled as Linda is with that procedure, but maybe there should be a "don't try this at home" disclaimer. I did not create any intorsion, which you generally get with the SRT. Admittedly, it's usually small enough that it's asymptomatic. No vertical deviation, which you sometimes get with SRT. Again, usually small enough that it's not a problem. And I didn't create a V pattern. In fact, his V pattern got better. And the V pattern is one thing that I find is invariable with the SRT, which I can't see how you could not get that with your main abductor being innervated in up gaze and inhibited in down gaze.
Well, that's a great result. I think that it raises a very interesting question, which is whether we as a community ought to consider expanding the number of patients that we do recess resects on who have Duane syndrome. I think the biggest fear has always been that you're going to worsen the co-contraction or the retropulsion of the eye. the cosmetic aspect of that more than a functional aspect of that. I think that in a case like this, where you have a very tight medial and you've been able to relax that medial substantially, probably the worsening of the co-contraction is relatively less likely because now that medial is not that tight and you don't have those two reins on the horse pulling the eye in. But it does raise that issue of whether the dictum of to avoid that is an overstated dictum, given the side effects of the many transposition procedures, no worse with SRT than with balanced transpositions, Nishidas, and the rest. I'm curious, what was his head posture and reading position? Did he still have this ET and down gaze?
No, he didn't have any problem in reading position.
That's great. That's a very, very interesting and a great outcome. And
Thank you.
Well,
appreciate
thank you. Thank you, Steve, for bringing up this new surgical option. I think it would be interesting, as Linda mentioned, to see if, as a community, we can get together and see how many cases we have out there and how safe it is to do it. In the past, we didn't do resections in thyroid patients, and now we know we can do them in select cases. So, which will be the cases that will be appropriate for a recess resect in Duane syndrome. So let's move on to the next case. Our next speaker will be Dr. Natalie Kerr. She is the Hyatt Professor and Executive Vice Chair of Ophthalmology at the University of Tennessee Health Science Center, Hamilton Eye Institute, and the discussant will be Dr. Steve Archer.
Thank you, Hilda. So this is shifting gears a little bit. It will bring back potentially some childhood strabismus issues that we deal with, but in an adult. So I'm going to present a 29-year-old who came in to see me recently with a lifelong history of eyes that just didn't move normally. She'd had no previous treatment, and she was only recently made aware that perhaps the motility problems that she had could be repaired. She only reported intermittent diplopia, so it was largely the motility issues that really bothered her. So this is what she looked like. I'll just briefly review the 9 gaze here. We have an esotropia and a left hypotropia in primary gaze. As we go into right gaze, there's definitely a limitation of ability to elevate the left eye in the adducted position. Probably not much of an overshoot there in the depressed position. When we go over into the left gaze, you can also appreciate that perhaps the right eye does not elevate fully in adduction as well, and that she also has a pattern to her esotropia. So let's see if we go forward here. So her measurements look like this. She had a 25 left hypo in primary gaze with a 30 left esotropia. This is measured over the left eye. So primary measurement. The left hypo gets worse in up gaze. The ET gets worse in down gaze, and the ET gets worse in left gaze, and the hypo gets worse in right gaze. On a tilt test, there was no difference right and left head tilt. She was able to fuse in free space with 30 base out, 20 base up over the left eye, so we weren't looking at any kind of ARC situation. She alternate suppressed on a Worth light. She had no demonstrable stereo. We tried to measure torsion. There was no demonstrable torsion on the DMR. And again, as pointed out in the slides of the motility, there was limited elevation in adduction, much greater with the left eye than with the right. So I'm going to pause it there. Probably the diagnosis is not a mystery, although you have to be careful with this one. And then the setting of it in an adult, I thought, created some interesting surgical questions and options. So I'll go back to this and I'll turn it over to Dr. Archer.
Okay, well, there's 2 features here. The esotropia, there is a little bit of a V pattern, not a dramatic V pattern. It's a little worse in left gaze. So I would do bimedial recessions for the esotropia, maybe a little more on the right eye than the left eye, unless the left medial is restricted or we find some other cause for restriction in side gaze, which we'll get to in a moment here. The striking feature is is the left hypotropia with limited elevation of the left eye, much worse in adduction. I'm not too impressed with that limited elevation in the right eye, but maybe that'll play in. So for that hypotropia with marked limited elevation in abduction, the two main things that you would think about here are Brown syndrome, of course, and inferior oblique palsy can really masquerade and look exactly like this. There's some things that distinguish them. The ductions would be a little better than the versions for an inferior oblique palsy. I'd like to see some intorsion. I'm not sure she really fuses, so whether subjective, double Maddox rods will get that. You might want to look at the left fundus. She doesn't have hyper on head tilt, or changing hypers on head tilt, so that kind of goes against inferior oblique palsy. And she's got a V pattern rather than an A pattern, which also doesn't go with inferior oblique palsy very well. Brown syndrome makes a little more sense here. It's a V pattern, but for a Brown syndrome this severe, I would have expected more of a Y pattern. I'd expect that left eye to shoot out in attempted upgaze. So it's a little funny for a Brown syndrome too. One that's this severe in a patient this age is a little odd. But of course, all will be revealed with the forced ductions at the time of surgery. The other thing that can do this, she doesn't have any history of inferior oblique surgery, but inferior oblique adhesion or adhesions in the intertemporal quadrant can do this. The other thing that that sometimes causes this is there can be little anomalous bands that restrict the eye movement, and you generally don't find these until you do the superior oblique tenotomy and find that you haven't cured the problem. Then you have to go hunting for them. If this really is a Brown syndrome and that's all there is, there are lots of conservative ways of lengthening the superior oblique. For Brown's this severe, I've always had to go back and do a complete tenotomy. So if it is the superior oblique restriction, I would do a complete tenotomy, fairly far nasal. If the eye is still hypo, with that, I might add a little bit of right superior rectus recession.
Okay, thank you very much. So where are we? Here we are. So that's our surgical plan. And I scratched my head a little bit about this. If this was a child and I found bilateral superior oblique restriction, I would have thought more about doing bilateral, addressing a bilateral Brown's, but I thought with an adult, you just want to make things look better. And actually I could maybe use, if there is a right Brown's, use that to my advantage to try to correct some of that huge hypo that she had on the left side. So in fact, I have an intra-op photo here. This is of the left eye. And I was trying to get a running start to extort this eye, and I could barely get it out there. And this was as far up as you could get it in a deduction. So clearly very positive forced ductions for a Brown syndrome on the left. She did have tightness on the right as well, though. So I'm convinced she does have a bilateral Brown's, just much worse on that left side. So considering that, one of the things when I've done adult Brown syndromes before is I would do the inferior oblique at the same time I did the tenotomy to try and balance out things so you didn't end up with the superior oblique palsy. I did not do that on her. I wouldn't have done it on a child. So I approached it more the way I would with a child, because I've seen that you really need that inferior oblique pulling that eye back up to get there after the superior oblique tenotomy, or I just haven't gotten the results that I've looked for when I've done a balanced inferior oblique recession as well on younger folks. So I didn't do that. I put this on a chicken suture and did a complete tenotomy. And you can see that it was pretty released afterwards. I left it hanging 1 centimeter or 10 millimeters, my little chicken suture, just in case I felt like this is an adult. What if I have to go back? What if she gets something very strange afterwards and is diplopic and I have issues with that? So I did that. And then I did a very simple, I just did a maximal medial rectus recession on that side. I had already warned her that I thought I would probably need to do 2 surgeries as I planned this out. So I tried to keep it very simple. And so this is what I ended up doing. Sometimes simple is good. I've only just done this a couple of weeks ago. First post-op week, she denied diplopia, and she was a 12 left ET and 8 left hypo, and she was able to fuse Worth lights at near. And this was her series of photographs. She's guarding a little bit in up and right gaze, but much better movement, and she was very pleased with the initial result. I wouldn't be surprised over time if we end up with an inferior oblique overaction or a reversal with a little bit of a left hyper, but I hope not, in part because I left her mild right Brown syndrome intact. So do you want to comment on that?
No, very, very nice result.
Okay. Sometimes simple is good, but she was a head scratcher for me coming in as an adult, because I count on these to get better, not worse, as they get older.
Thank you so much for sharing that case with us. We're going to move on to our last speaker, Dr. Linda Daggy, Associate Professor of Ophthalmology at the Harvard Medical School, where she's a Director of Adult Strabismus. She's also at the Boston Children's Hospital. And the discussant of her case will be Dr. Mustafa Abdel.
Okay, Mustafa, are you with us?
Yes, thank
Okay,
you. I'm
great.
with you.
Wonderful, wonderful. So I decided to entitle this just for fun, and it's called How to Ski and Sail Equally Well, because my particular patient was a competitive sailor and a competitive ice hockey player. I guess we have to advance these that way. So to be simple about it, he's a 67-year-old male who developed an acute onset partial ptosis, left eye, and an exotropia, and vertical misalignment, and an image tilt while driving down 95. He had his wits about him and actually drove himself to an urgent care center, and there was mediflighted to a hospital for treatment. He was treated at this hospital, and long story short, over a year, the ptosis resolved, but he was still double everywhere and had to give up his competitive sailing and ice hockey playing. He had a history of hypertension, hypercholesterolemia, and a B12 deficiency, but actually was a very functional, very active businessman who had these major sports as hobbies. And here's his alignment. He had normal acuity, anterior segment, fundus exam, visual field, and color vision, all not relevant to this case. He was left after this acute event with an exotropia worse of the left eye, worse in right gaze, more limited adduction, as you can see from the ductions, and a left hypotropia, which persisted in most cases, but worse in left gaze, not terribly concomitant up and down, but worse in left gaze. Not too much difference with head tilt. Double Maddox rod had a net X cyclotorsion that was pretty dramatic of 12 degrees, and he was aware of this torsional diplopia as well as the vertical and horizontal. And this is what his ductions look like. The numbers look bigger than he looks in these images, but you can perhaps appreciate that the left eye is relatively hypotropic, and the hypotropia is worse in left gaze. And his exotropia is worse in right gaze because the left eye cannot adduct so very well, and the left eye is unable to fully elevate. And his question to me was, will I ever be able to skate or sail again? This was his major concern. So what do you think was his likely diagnosis? But more importantly, how would you treat his strabismus? So I'm going to go back. I think the pictures are a little harder to look at because they're not that dramatic, but I'll go back to his numbers, which might help with the discussion. So what do you think?
Thank you, Dr. Linda, for this complex case. I think it's a combo case. It seems from the history and from the left eye that he had partial cell nerve palsy with mild limited adduction in the left eye and limited elevation on abduction in the left eye. But I think it's not the only thing, because he has tilted image and torsional diplopia, I think. We see the yoke muscle, which is the right inferior oblique, it seems there is overaction in the right inferior oblique. It gives us positive head tilt, right hypertropia or left hypertropia on the right head tilt. The exotropia increased on up gaze due to the superior rectus in the left eye, paresis or palsy, I think, plus the inferior oblique overaction, or if there's any element or issue of superior oblique palsy or paresis, either in right eye or bilateral. If they are bilateral, the double Maddox rod will give us around this number, and it gives high or large the V pattern that the patient had. Rather than the superior rectus itself or the superior rectus palsy increases the exotropia on up gaze. The torsional or the fundus torsion in the left eye, I don't know what, I think there is extorsion in the right eye for the fundus, and there is some extorsion in the left eye, especially if he looks to the left. But do you think, did he have extortion, fundus extortion in the left eye when he adducted the eye, or he didn't have?
You know, I didn't look, in all honesty, more in AB or a deduction. He had a bit of extorsion in both fundi. He fixated with his right eye and had a net excyclic torsion measurable in his left. But as you know, you can measure the torsion in either eye. It will move to the non-fixing eye when you measure with double Maddox rod. So certainly extorsion is notable. What would you, regardless of the etiology, how would you like to treat him? What do you want to do?
Okay, number one, I prefer to resect the left medial rectus. Number two, I prefer to resect the left superior rectus rather than recession for the left inferior rectus. Because he had partial third nerve. That means the inferior rectus in the left eye may be affected a little bit. So I prefer the superior rectus resection in the left eye plus medial rectus resection in the left eye, plus we can weaken the inferior oblique either in the right eye or bilaterally. I would do right inferior oblique recession plus minus left inferior oblique minimal recession, or will make it unequal or asymmetric in both eyes and more in the right eye. This asymmetric or the left inferior rectus, inferior oblique recession will depend on the amount of fundus extortion. If it's equal in both sides, I will do the recession. If the extortion is more in the right eye, so I prefer to do only one inferior oblique recession in the right eye. And the inferior oblique recession will help in the V pattern. The resection of the superior rectus in the left eye will help in the hypotropia, which greater in the left gaze. And it will help, if I do nasal shift, it will help in the exotropia and up gaze. Resection of the medial rectus in the left eye will help the exotropia, especially on the contralateral gaze. I don't know your opinion. I think this is my suggestion for the patient.
Great. So I'll tell you what I did and why I did what I did. And I'll tell you that I ended up doing it in a staged manner, though not initially by intention. So he had a microvascular stroke. And the interesting thing about this guy is he's a very intelligent man. And he said to me as I brought him in, he said, I studied science. I knew I was having a third nerve palsy. My lid was coming down and my eye was floating out. It was the most astounding thing. This guy's a businessman. He said, I knew I was having acute third nerve palsy. I just knew it. So that's why I went to an urgent care center. I just wanted to share that with you. He had no serious background in science other than what he learned in high school. So I was pretty impressed. This was a microvascular partial third nerve palsy with the biggest impact after recovery on the superior rectus and the medial rectus. You can see this limitation of the greater hypotropia, really fully recovered, I felt, inferior rectus function. Why such cyclotorsion? I thought this was due for two reasons. First, he had an unopposed inferior rectus. It's an cyclotorsion. You lose all your encyclotorsional tone of the superior rectus. And he thought he might actually have a partially weakened superior oblique without a true hypertropia in that side, because he was sort of hypotropic, but it's sort of not so obvious inferior oblique overaction. But I decided to handle it fairly simply, dealing with trying to reduce his cyclotorsion, his vertical and horizontal. And I did a left eye medial rectus recession, a left eye inferior rectus recession. I know you talked about a superior rectus resection, but he had such excellent inferior rectus tone. I thought if he had a flaccid superior rectus, I would get more bang for my buck. And this, by the way, are his pre-op measurements, just repeated for you. And I needed to reduce that profound left hypotropia in reading position. I did a right lateral rectus recession for the size of this concomitant exotropia because I didn't want to do 3 rectus muscles on a vascular path. So I wanted to reduce the risk of anterior segment ischemia, and I thought this would reduce the concomitant XT, reduce his hypotropia, and help significantly with his cyclotorsion. And in fact, he was initially fine. He was fine for a good several months with some intermittent vertical diplopia, intermittent left hypotropia in down and left gaze, fusing with a small chin down posture and head turned to the left. And he resolved his XT, regained 80 arc seconds of stereo. He had no area of fusion before, diminished cyclotorsion down to 7 degrees and regained excellent convergence. But over time, his intermittent left hypotropia returned, worse gaze left and down gaze. So over the course of about a year, this is what happened. This was his sweet spot shown up here, fusing beautifully in up gaze for his sailing. This is an intermittent, not fully tropic hypotropia, but still pretty large in down gaze, in spite of that large inferior rectus recession, because the superior rectus just wasn't really functioning at all. So it is best fusion, chin down, gaze right. And he really was pretty okay with that, but sailing wasn't his only interest. He was a big ice hockey player as well as a businessman, and he needed to be able to look down, run down a flight of stairs, read well. So I said, well, let's go back to the OR. And we did a second procedure. My concern was fixing down gaze without really sacrificing much in up gaze. And he'd already had a significant, let's go back to how much we did, an inferior rectus recession of 6.5 on the left. I didn't want to fully cripple it to deal with a very large increase in his inferior rectus recession. And here's his measurements. So I ended up doing part of what you talked about at the beginning. I did a right inferior oblique recession, which is the value of looking at contralateral surgery for partial third nerve palsies, because if you can use your opposite eye, and in this case, inferior oblique recession helped reduce further the cyclotorsion. And I re-recessed the inferior rectus only a small amount. And it gave him 40 arc seconds of stereo, no corticalis, no ocular torticollis, no torsional diplopia, and he was able both to skate and to sail and to compete. And so this was an interesting case. If we go back to the beginning of looking at this, of the value of reducing inferior oblique function on the opposite eye, as well as the inferior rectus function on the ipsilateral eye, and then dealing with the concomitant strabismus. And reducing the inferior oblique as well as the inferior rectus will reduce some of that significant cyclotorsion. And so that's why I wanted to present this case, because it's sort of fun to think about it both in torsional terms and in terms of using your contralateral eye to help. And that's it. Thank you.
Cool. Thank you to all the presenters. I think these have been great
Thank you,
cases.
Dr. Mann.
I don't think we have much time. Maybe we want to make a comment. I was surprised that you didn't do R&R horizontal in the right eye. You did lateral on one eye, medial on the other.
Well, I did that to improve his medial tone because he needed
Yeah.
something to, I should stop sharing. He needed something to improve his medial tone on that left eye. And I did that's why I chose what I did.
Yeah. So we have a couple of comments. I think when Steve Archer presented the R&R for the Duane syndrome, we have actually Steve Kraft sent a message. He has done almost 20 patients over 20 years in which he has recessed the medial rectus and resected the lateral rectus muscle. So it may be happening more frequently than we know of. Probably somebody should publish it so to make it available. But interestingly, we got other comment, and it was, and probably Steve can comment on that. They were questioning if you are resecting a muscle that is denervated, how much effect you expect to get from that.
Yeah, I should give credit to Jim Mims, who was I think the guy who revived the idea of doing recess resecting Duane syndrome, and Steve Kraft picked that up and has done many more of them, and he is actually where I learned that from. He presented a case when I was visiting there that was a spectacular result, and so I've been using that in selected cases ever since. As I commented, it's not a denervated muscle. It has innervation. It's just anomalous innervation. So it's a little different from a complete sixth nerve palsy. And I think the other thing is Linda mentioned recessing the contralateral medial rectus muscle if you needed some extra help. And that's why I put the comment in there about putting a 30 base out prism over the sound eye to see if that helped his face turn at all, and it didn't. And it usually doesn't in Duane syndrome. The problem is that it's not like a sixth nerve palsy, because if you the idea is with a sixth nerve palsy is you recess the contralateral medial, which increases the innervation to the weak lateral rectus muscle. But Duane's is different. There's no innervation to increase by doing that. What you will do is you will decrease the innervation to the medial rectus muscle on the opposite side, which could help you a little bit, but that also decreases the innervation to the lateral rectus muscle simultaneously. So every case is a little different, but by and large, you get nothing. It's a wash in most cases.
Yeah,
Anybody else has a comment? Yeah, go ahead, Linda.
I think that Steve has actually published this series. Steve Kraft has actually published this recess resect series. He can maybe tell us in the chat whether he has.
Okay, anybody in the panel has any additional comments, questions? So I think it's time to leave. I think we were scheduled to finish at 9:10. We're at 9:15, but not bad. Thank you again for all the panelists for presenting such interesting cases. I think we saw a little bit of everything, how sometimes one surgery is not enough. We may need 2 surgeries in many of these patients, and this is good for the audience to be aware of it. I want the audience to know, please answer the post-webinar questions posted by AAPOS in the link in the chat session. Also, you will be getting a link to the recording and a certificate of attendance if you desire it. We will hope to continue this webinar on a yearly basis, and we'll appreciate any comments or suggestions that you may have. So thank you all, and have a good night.